So good afternoon. My name is Carol Clausen, and on some days I'm the Vice President of Knowledge and Technology Services. But for the last week, I've been the team lead for RPIW1, which is at the Regina General Hospital, the ER from the door through triage and into the waiting room. So every day, 148 patients come through that door. This is the standard work combination sheet showing the agenda that we're going to present to a tack time of 20 minutes. You'll see the next is a team photo, and each person will introduce themselves as we present the story of our RPIW. This is really the project form that was signed off to guide the work of the RPIW. The goal was to improve accurate, efficient, and safe patient care with respect to triage and registration of our patients. The current situation means that patients and families who come through our ER doors often experience confusion and frustration, and they are required to find the right line first to register, then to get triage, the right line to register their vehicle for parking. We also recognize that there's a lack of standard work in the important area of infection control, and the flu season is coming. So the next form shows you, it's our target progress report. And we were really focused much more in terms of reducing unnecessary movement of our patients and improving flow. So you'll see that in terms of the patient steps and the steps. And as well, we looked at reducing wasted paper. Our target, as you can see, really was to look at lead time, and that's reflected in the focus on reducing the non-value add wait, particularly between registration and triage. And lead time, for those of you who don't know that term, is just the total length of time from when the patient would come in the door until they actually would leave the waiting room for treatment. We also identified some defects to focus on, and this is really to emphasize the whole area of safety and patient experience, noting the interruptions a triage nurse has, looking for standard work, particularly in infection control, eliminating some of the frustrations around parking. When you look at our 5S score of 1, we had room for improvement. So in the end, you see our goal was not to reduce the number of patients coming in our door or to reduce the amount of time that our registration and triage took, but it really was about improving the experience of our patients. So our team is going to tell you about what we did, what we accomplished, and the story of that journey.
Hi, I'm Melissa, and I am with the KPO, and I was the KPO support for this week. One of the first things that we did in week -3 was we developed a tack time calculation sheet. And on our tack time calculation sheet, we looked at what was actually coming through, so the pace or the rate of which patients are coming through the emergency doors and receiving their triage and being registered and then being roomed. So we looked at what happens within a 24-hour period, a 16-hour period, and an 8-hour period. And within a 24-hour period, we have approximately 148 patients that are coming through the doors, and it takes about 9 minutes and 43 seconds. And within a 16-hour period, we had 124 patients coming through the doors, and that was taking 7 minutes and 44 seconds. And then in an 8-hour period, we actually had 24 patients coming through the doors, and on average, that was about 20 minutes per patient. From there, we then developed the current state map, and that was done through a lot of our observations, doing spaghetti maps, and we were able to really see the flow of the patient. So it went from the time the patient went through the doors to triage, registration, and then the time that they were roomed. In developing this, we were also able to identify approximately 21 new improvements, and all of those improvements are the red circles that you'll see on the current state map. And through this week, we were actually able to get through quite a few of those new improvements. From there, we then developed a future state, and on the future state, what this really illustrates is having the patient come through our system, so through the doors, and instead of having 2 stops, they're able to go to the registration and the triage area, which would then become 1. And they would then be roomed not by a push, but by a pull. After we developed the future state, we also did a waste walk. And we did the waste walk with our team. And these were all of the different types of waste that they were able to see within that environment. So all the 7 different types of wastes. And then we did a waste walk post-Kaizen, which is now what we were able to achieve. So we were able to eliminate quite a lot of waste within the system.
Hello, I'm Wendy Bright. I'm a child life specialist with our region, and I'm the patient. And when patients come to emergency, they are already overwhelmed and confused before they step in our door. When they get in our doors, we realized some of our signs were a problem. We had signs that were confusing, in the wrong place, and we actually eliminated some of the signs. We removed a bunch of different signs. I also removed 8 thumbtacks and 5 push pins that are not a safety in our emerge. So we removed some of those, and of course we're running into cold and flu season, and our lovely mask picture was actually hidden behind a column, and it's now been moved in a more appropriate setting so people can see it. And also we've moved information where it is important. Okay. Now, you can see we have our spaghetti chart shows that our patient flow is very confusing. They come in, there's 2 different lines, they line up in a line, they get to the point, and they say, oh, you need to be in the other line. So they go to another line. And a lot of mass confusion, which means the patient is going many different directions, and they had over 52 steps in their process. And we wanted to change that process. So our idea map shows that if we combined our triage and our registration together, we can have the patient flow much smoother. So we had our patient come in, sit down or stand. They were registered and triaged. The patient did not move. The staff came to the patient. And this aided in less movement for the patient, and it ensured that the patient is more engaged in the process. And our post-Kaizen spaghetti map shows a reduction of steps to the patient down to 41. And this is valuable learning experience for everyone. And I appreciate the fact that you involved the patient. And I'll pass it on to Scott to give you more information of our process.
Hi there, I'm Scott. On any normal week, I'm the unit coordinator at the General Hospital Emergency Department. This week, I've been working with the team in regards to registration and triage for patient flow. As you can see on the standard worksheet that we have up there, the pre-Kaizen steps that the registration clerk would take on any normal day is quite extensive throughout the department. The post-Kaizen spaghetti map here shows how we've reduced that by combining registration and triage into one physical location. As well, for the triage nurse, the next standard worksheet shows the pre-Kaizen steps that were taken by the triage nurse at any given day is quite extensive throughout the department as well. And the post-Kaizen spaghetti map illustrates just how we've reduced those steps considerably. Next up is the time observation form, which shows pre-Kaizen that on average it would take 2 minutes and 54 seconds for a registration clerk to register 1 patient. Post-Kaizen, the registration time actually increased to 3 minutes and 15 seconds. However, as you'll see later on in the presentation, there's been some load leveling with work distribution that's led to that. The pre-Kaizen time observation form for triage was 5 minutes per patient to be triaged, and post-Kaizen was 4 minutes and 30 seconds, which is a reduced time as previously. By doing this, combining one space for the patient to come to, we've reduced the confusion of a patient entering the emergency department from having those several different patients, and a confusing flow to one physical space that the patient comes to is registered, then triaged without having to move for a second time. This eliminates wait times just based on the flow aspect of it. By doing this, there was another unintended result that we noticed. Having one physical space for both registration and triage to do their work, there was a wait, register, wait, triage mode for flow. That is now reduced to a wait, register, and triage, and then flow out from there. As well, the standard worksheets, the combination sheets, just show the further illustration of the pre- and post-Kaizen in both the work allocation for registration and triage.